advanced. It changed it from the current structure, which is sort of an open-ended entitlement with a match rate to varying levels depending on where you are in the state and what program it is, to a per capita cap model that kind of has a complicated formulary, but it would end up over 10 years, the CBO estimates, cutting around $885 billion, I believe, from the Medicaid program. That means that states would have to rejigger the way that they design the program. Likely areas that they would want to cut because of their cost are certain drugs, long-term care services, that type of thing. It's still very much to be determined what would happen, but you could see like high-cost services being targeted for cuts under the Medicaid program if that were to go into effect. A lot of the costers in the bill came from basically the repeal of all of the taxes imposed by the ACA as a part of the way to pay for the legislation back in 2010. That would include med device and the pharmaceutical tax, which we could lower consumer costs somewhat. It also changed the way subsidies are structured under the ACA to be a flatter level index based on age. So it would expand who is eligible for the credits, but in some instances lower how much they could get. Let's see. What else is it? There's a couple other things. I'm just trying to think about what's most important to you guys. It would also repeal the current age rating structure, which is a 1 to 3, the younger you are, you get, that's pegged on a 1 to up to 3 times as much for older individuals. It would change it to 1 to 5 so that younger individuals would be getting lower premiums, but the age-based tax credit would increase with the older you are. So it kind of sort of evens out, kind of depends on particular circumstances. It also did away with the actuarial value requirements, which under the ACA, they're based on metal tiers. The bronze level is 60% actuarial value, gold is 70, or silver is 70, gold is 80, and platinum is 90. By doing away with actuarial value, CBO estimated that without removing the EHB requirements, the essential health benefit requirements, and out-of-pocket limitations under the law, that it was unlikely that plans were going to dip much farther below 60% actuarial value, but it would mean that under the ACA, you're required to offer on exchange a silver and gold plan. With doing away with that requirement, it means that there would be a lot more bronze level plans available and a lot fewer silver and gold level plans. So it's kind of high level overview. There were a couple of managers amendments that came about based on negotiations trying to get particularly conservative, more in line with the package. One was to do away with essential health benefits requirements. Another was to inject a sum of money, and there was a sum of money in the base bill to allow for some state innovation, different ways to provide coverage, particularly towards lower income people. And this would inject about $15 billion into reinsurance over 9 years. At present, we don't necessarily see a path forward for the bill, certainly as is, but we think that particularly there's something called cost-sharing reduction subsidies that people with lower incomes are shielded from much of the cost sharing in the individual market, and Congress is supposed to pay insurers to shield that cost sharing for beneficiaries or for enrollees. That has not been funded for 2017 or 2018. So if plans that are currently under contract, currently servicing enrollees, are not paid to service them for 2017, we find it highly unlikely that they will participate in the levels they are currently. We've already seen people dropping out of the exchanges. And if they do, then they will have to increase their premiums to meet those requirements. Kaiser Family Foundation has estimated that on average that would mean a 20% increase in premiums just for cost-sharing subsidies. That doesn't factor in medical trend, risk pool, et cetera. For states with lower incomes, the impact is even greater. For instance, in Mississippi and Alabama, about 75% of enrollees are cost-sharing reduction eligible. So that's kind of the state of play. We feel like if the markets continue to deteriorate, we see a number of plans dropping out or having significant rate increases for next year, that there could be some bipartisan action to help stabilize markets. which could include some greater reforms. So sort of the state of play with the AHCA. Still very much unknown what happens going forward. The thing that I think is important and people aren't talking about enough is that a lot of the ACA in statute is fairly broad and there's a lot of secretarial discretion on setting these rules. One thing that has not changed so far in regulation, but we anticipate changing over the next year, I would expect for plan year 2019, is to significantly change the essential health benefits regulations. Right now, it's a benchmark structure where a state chooses a benchmark based on kind of three large buckets. It's the FEHBP Blue Plan, the most popular state employee plan, or the most popular small group plan. I believe most states have picked the most popular small group plan. And part of that is also kind of mirroring the formulary, and there's a requirement in the regs that you have to have at least like the number of drugs available within the formulary for each class and category. So all of that can basically change. Under statute, there are only 10 broad categories that you have to have a drug benefit, but it doesn't say you have to match these formularies to any sort of extent. Something I personally worked on that I think could be relevant to a lot of people that is very much kind of unknown to people outside of the sphere. I was involved in Maryland in picking their benchmark, and there are lots of specifics in these benchmarks that are not included in statute. Like the statute is very broad. It's rehabilitative services, habilitative services, inpatient. It doesn't say exactly what that means. So things like medical foods is not really included in any of these categories, but they are in the benchmarks to a large extent. And medical foods can obviously be very expensive. And so if states are given a lot more leeway and it's a very regulatorily light state, you could see something like that falling out of the benchmark. You could see a lot more leeway in what counts as rehabilitative services. I just think that that's something that is not really being paid attention to enough. Even if EHB stays in statute, which I think it will, there's a lot that can be done through regulation to change this up, including just diverting it to states, just saying that they can certify whether it meets EHB or not, and just getting rid of benchmarks altogether. So those are a couple of key things I think that should be on everyone's radar. Additionally, some lab testing and different types like that in medical devices. Is there any questions?
Does anyone have any questions for Katie? I'll be opening up the lines now. All right, does anyone have any questions? Okay. Thank you for joining us.
Thanks for having me.
So we make sure we know how to open the line.
What is it?
You write down that we make sure we open
Yeah.
With that, I will be remuting the line momentarily. There we go. Works. Okay, there we go. All right, and next we have Paul with Nord, who will be giving.
Hey there, this is Paul. Can everyone hear me?
Yep, we can hear you.
Very good. So, hey everybody, this is Paul. I'm with the National Organization for Rare Disorders, and we just wanted to give everyone a quick update on our work with the user fee agreements and an opportunity to sign on to a coalition letter that we are working with the National Health Council on that encourages the swift passage of the user fee agreements through Congress. So before I get into the letter itself, I'm sure that many of you are aware of the importance of the user fee agreements, but for those of you who may not, the user fees are incredibly important in funding the FDA, and in ensuring that the FDA is reviewing orphan therapies quickly and with the expertise to be able to be sure that the innovative therapies in front of them are reviewed flexibly and equitably, and that the innovative therapies are reaching patients as quickly as possible. Within the UFA agreements themselves, there are certain policies that we believe could be very beneficial to the rare disease patient community, including the expansion of the rare disease program into the reviews of orphan therapies within the Center for Drug Evaluation and Research, as well as the Center for Biologics Evaluation and Research. There is also the continuation of the patient-focused drug development initiative and the further quantification of the patient voice within the drug development and review process. And then there are also important provisions within the Medical Device User Fee Act that would also accelerate the development and review and patient input into innovative medical devices. So for this reason, we are circulating a letter to the patient organization community that reiterates the importance of the user fee reauthorizations to patients. And it's not a rare disease specific letter. This is for any patient organization that wishes to sign on. But the letter essentially just says, hey, Congress, the user fees are important because the FDA is important to making sure that we patients get the therapies that we need. And we need to be sure that the user fee agreements are not held up in any kind of partisan or, a bickering kind of way that, unfortunately, policy seems to be more and more held up in these days. So our letter can be found on our website. It's at rarediseases.org over on the news section on the bottom right. It's actually the first post over there. And it's also on the RDLA website. It is at rareadvocates.org, on the, I think it's the middle link there, there's an opportunity to sign your organization onto the letter there as well. The deadline is tomorrow, COB, so you still got this afternoon and tomorrow to look at it, and we're very hopeful that you'll join us. Thank you.
Great, thank you, Paul. That was definitely informative. Let me just open up the lines now. If anyone has any questions for Paul, you can feel free to ask it now.
If you guys are on the line, you can just use your own phone. That'll help the background.
Hi, Paul. Sarah Tompkins with Ehlers-Danlos support group at UW in Washington. Can patient advocacy groups as well as potentially individual patients sign on to this, or is it just patient advocacy groups or organizations?
So this letter specifically is just for patient advocacy groups and patient organizations. However, I would anticipate over the next month and a half, as the UFA process continues, there will likely be additional opportunities for individual advocates as well.
But for this, can sign on
but for this letter specifically,
great.
In the future, but this for this letter specifically, just patient organizations.
Oh, excellent. Thank you for letting me know this differentiation.
No problem.
Great. Does anyone else have any questions for Paul? Okay, well, thank you, Paul. And with that, we'll be moving over to Kara Toman, who's joining us from BIO to discuss the BIO's principles for patient engagement.
Thanks. I thought that I would begin by just doing a little level setting and telling you a bit about BIO and why we felt it was important to write these principles. So for those of you who don't know, BIO is a trade association headquartered in DC. We have about 1,000 member companies. Most are in the healthcare space. And we're a big tent. Our members range from the very large biopharmaceutical companies to what we call emerging companies, those small and medium-sized companies that are still working to get their first product to market. So just over a year ago, well, let me back up for a second. BIO is governed by a board of directors, like many organizations. Within our board, about 3 years ago, the board decided to create a board-level patient advocacy committee. And this is a committee structure to really make sure that the patient's voice is well represented in the decisions that our board makes. About a year ago, when our board patient advocacy committee was meeting, they sort of directed staff to come up with a set of principles to help guide how our industry, how bio and our members interact with the patient advocacy community. We're very proud of our partnerships with the patient community, and we really wanted to use this as an opportunity to, one, sort of provide a guide for bio members to consider how they interact with the patient community. Like I said, many of our members are small and medium-sized and kind of still figuring things out, so we thought that this might be a helpful tool for them. But also, we wanted to make these principles publicly available to demonstrate to the patient advocacy community the value we place on their partnership and their role as a trusted voice for the patients that they serve. So we set about drafting, well, first coming up with sort of a set of themes that a document of this type should encompass. So we just kind of polled friends that we have in the patient community, groups that we work closely with, to learn what themes, what ideas would be most important to them. And then from there, we worked with a working group comprised of members of our member companies to kind of work through the drafting of the principles. From there, they were approved by our board patient advocacy committee and then the full health section governing board. And the principles now live on our website. They're publicly available. Hopefully you've seen them. If you haven't, I hope that you'll check them out soon. And then we share them, of course, with all of our members and broadly the patient advocacy community. And just to touch on the themes, we sort of open up the document by just giving a little bit of background about why we felt these principles were necessary and about the partnership that our industry and the patient advocacy community has traditionally had and the importance of the patient advocacy community as that independent voice that truly represents what patients want and need. From there, it falls into a couple different buckets. Fostering partnership and valuing independence. The core of this bucket is really to say that patient advocacy organizations are independent organizations. They set their own agendas. In many cases, our priorities do align, but in many cases, they will not, and that is okay. The next big bucket is advocating for policies that improve patient outcomes. As I mentioned, at its core, BIO's primary mission is to advocate on behalf of our members on Capitol Hill and in front of regulatory agencies and state legislatures, and many patient advocacy organizations do the same. They're advocating on behalf of their constituencies as well. And from time to time, we partner up when our priorities do align. So we just wanted to address that in the principles as well, that those partnerships, when they are formed, that each partner is treated as equal. The next bucket, supporting patient advocacy organizations. We did want to address that from time to time, industry does provide financial support to patient advocacy organizations, but that support should not be used to help dictate a policy position or dictate any specific action by a patient advocacy organization. It's really just to help strengthen the mission of the organization. Next, valuing the privacy of the patient community. This just says that any data that may be collected, patient groups more and more are collecting a lot of data about their communities, that remains with the organization and that there's no expectation from our members that they will have access to that data. And then finally, respecting standards of ethical conduct. We just wanted to make clear that we as an industry, BIO and our members respect the relationship that a patient has with his or her doctor and the clinical decisions that need to be made. So like I said, these are available on the website. We're very proud of them. Hopefully you all like what you hear and read. But with that, happy to take any questions you may have.
Great. Thank you, Kara. I will now be opening the lines for any questions that anyone has.
Kara, this is Max from EveryLife. Just a question about how have the companies responded to this membership? Are they excited about these principles that they wanted to edit? I'm curious.
Yeah,
really involved our members really from the start to finish. So we took a look at existing principles that currently exist. Many of our member companies already had principles. And then, like I said, we formed a working group of our member companies to kind of help us through the drafting process. And, you know, it's working for the trade is very different than working for the company, so it was really, really important to have their perspective. And then, you know, it went through the board level. So I think that there is a lot of buy-in from our member companies. The bigger companies may have their own principles, policies in place, but I think this is especially helpful for those smaller and medium-sized companies that are still kind of finding their footing and making their way through this. I will also say, I mean, they're only a year old, so I don't think we're going to open them up anytime soon, but I do think that it will be an evolving document because patient advocacy is an evolving field. You know, the things that patient advocacy groups, I mean, just in the past 5–10 years have become so much more sophisticated. They're not just focused on advocacy and awareness anymore. They're venture philanthropies. They are really, really integral to the drug development process. So, you know, I think maybe in a couple of years, kind of take a look and see if we can jump anyway.
Great. Does anyone else have any questions for Kara? And real quick, if you're in a noisy place, we definitely ask you to please mute your phone.
I had a question.
Sure.
Hi.
It sounds like
Sarah
someone...
Tompkins. Oh, there. Hi, Sarah Tompkins. I was wondering, what was the website specifically that we could visit to look at all this data and output principles?
Yeah, the website is bio.org, and you may have to search patient advocacy principles, but we can also send out a link to the PDF as follow-up.
Oh, thank you so much. I'm sure off of bio.org I'll be able to find it. Thank you.
It's also been shared by Stephanie Fisher. And I will actually share it more broadly in everyone's chat window. So if you open that up, you'll find it at bio.org/bio_patient_engagement_principles.
Thank you so much for sharing that.
Of course. Does anyone else have any questions? Okay, great. With that, I am going to pass it over to Steve Grossman. Steve, are you there?
Yes, I am here. I don't have WebEx coming through, so I'll just have to sort of fly blind in terms of what slides up.
Okay. I'll follow what you're saying.
Okay. Very good. Thank you again for the opportunity. I think this is my second time this year, and I hope by now everybody is familiar with the Alliance for Stronger FDA. We have 150 or so members, consumers, patients, industry, health professions, societies, the entire gamut of FDA stakeholders, and our goal is to increase the appropriated resources to FDA. For those not familiar with the history, the agency has been historically underfunded. We've managed in a decade to add more than $1 billion to its base appropriations. We're in the neighborhood of 60%. So, and we would say it's still not adequately funded, but we've come a long way. I'll get to the punchline, then come back to sort of the sort of pitch and what's going on this year in particular with FDA. We are having our Hill Day next Tuesday. Anybody who can send me an email or send it to Viggy and he'll pass it on to me. We would be happy to have you join. You don't need to be an Alliance member to join our Hill Day, and we would be glad to have others who understand the FDA cause and would be willing and eager to talk about it on Capitol Hill. So with that note, let me just sort of go back and kind of, well, where are we? Why is this so important? in general, and then so important, particularly this year. FDA is probably most of you know, vitally important, underfunded for decades. The agency gets $2.72 billion, and with that it oversees 20% of all consumers, of the goods that consumers spend money on. It's food, that's drugs, it's over-the-counter, it's cosmetics, medical devices, and it goes on because all of them are ones where it makes a difference. There's standards that everybody in the marketplace. The agency also gets user fees. Important distinction: user fees, which get a lot of attention, are meant supplemental. They were never meant to replace taxpayer monies that go for the core public health functions of the agency. For purposes of comparison, medical product user fees come to about $1.35 billion. That's without tobacco user fees, because that's really a whole different thing. So a gross level, about a third of the non-tobacco agency is paid for by user fees, and 2/3 is paid by appropriations. Then we get to, well, what does the president have in mind? And I don't know whether it's better to have a nuanced, subtle attack or have a front-on attack, such as the way NIH is. But in the case of FDA, they've chosen a nuanced approach. What they've proposed is to increase the medical product user fees by $1 billion, more or less doubling them. And it's in exchange for unspecified process improvements. To the best of my knowledge, there's an awful lot of industry has things they would like to see improved about FDA, but I don't see anybody who's looking at anything they pay significant money for above and beyond the user fee for negotiating last year and on Capitol Hill this year. Now, by itself, that doesn't look so bad, because FDA budget will look like it's getting something resembling level funding. However, the effect is to shift $1 billion on budget through budget authority appropriations to $1 billion off budget through user fees. And that reality is going to be hard. Let's go to the second one. We don't know all the things they have in mind, because it's one sentence, no details. But this is an large, totally unplanned increase in user fees, and it raises the issue, since user fees and industry and FDA all negotiated this over the last 2 years. Congress is determined to get it done before summer. Where this fits in all these things. Does this mean that the administration is going to oppose the user fee agreement? They're wending their way through Congress right now. I think we all hope not. It would create a very sort of an end game for FDA that could be a lose-lose. And so far, good news, the Hill isn't that interested in the Trump proposal. They're sticking with what's been negotiated, which, as I've indicated, is a significant amount of money. What's the real risk? The real risk is by shifting money on budget to off budget. What the administration has in mind is paper saving of $1 billion that goes towards the $54 billion that they're trying to achieve in order to shift funding to defense and homeland security. What happens is that shift creates a problem for the appropriations committees. On the one hand, it looks like the administration is supporting the agency by saying, give them approximately the same money they had last year. In fact, when the appropriations committee instead of seeing a request for $2.7 billion in budget already appropriated, they're going to see a request for $1.7 billion authority applications, and missing $1 billion in user fees is never going to happen. So that's a risk that we're part of the Agriculture Appropriations Committee. People who in that programs in that subcommittee with us are all in USDA, and they're already looking at a 15 to 20%. That the Appropriations Committee is not going to be able to find $1 billion to make up for what looks like a paper cut that actually is probably going to turn out to be, or could turn out to be, an act. Our Hill Day is next Tuesday, April 25th. We're trying to do 50 to 65 meetings on the Hill. We've pretty much got them lined up, but we could use some more people to talk about why, and for the purpose of this call, why patient groups are concerned about FDA, how they see FDA being strong helps innovation and helps move therapies along that are going to help their. So just to summarize, broad mandate, relatively full agency, function of government, interested in participants, want to know more about the Alliance, LAD Executive Director, my email, and that last slide. That's it. Questions?
Thank you, Steve. It still sounds like someone's got their line unmuted. If you're in a noisy place, we definitely ask you to please mute your phone. Does anyone have any questions for Steve? It appears we've got one from Sarah Tompkins asking whether there's a way to participate in the Hill Day for Hill Day remotely if you live on the West Coast.
We're not that sophisticated yet.
No problem. Good to know. Thank you.
Well, actually, can we have a sidebar conversation, not take up everybody else's time, about how you assume the question, having done this before, remote, and I'd be interested in how that worked, and maybe it's something we can add on for the next time.
Sure, absolutely. I would really appreciate that.
Does anyone else have any questions for Steve?
Hey, Steve, this is Max from the Every Life Foundation. Just curious if you could comment a little bit on, now that initially when the new administration came in, we had a hiring freeze in place, and now that's transitioned to more of a workforce reduction plan. So I'd just be curious if you could add some more details on how you all have interpreted that in terms of what that would mean to FDA and, what advocates could be doing about that situation.
I'd be happy to. Thank you for the question. And the new announcement came down last week. I was thinking, and everybody said, oh, what good news. The hiring freeze has been lifted. And like you implied, and everybody ought to understand clearly, far from being the end of the threat, it's the next step in reducing the workforce, and everybody's going to pressure to comply with the requirements. For FDA in particular, I'll get into the details, staff reductions are particularly critical to the agency. The agency is particularly vulnerable because over 80% of the agency's budget is spent on personnel-related costs. Different than expand contracts, and their workforce expenditures can be significant, but there are very few agencies for which it's 80% or more. So that when we talk about more money for the agency, we also are fully advocates for a workforce big enough to carry out the work, because if you don't have enough people, they can't do their job, just as if they don't have the money, they can't do their job. Okay, so what's going on? The original employment freeze came with a set of directions about 2 weeks later from OMB. It gave a lot of job category codes that were excluded from the hiring freeze. Many of those align with FDA job vacancies, and so at least theoretically, FDA was not fully constrained and could have been doing some hiring. It's not clear whether they have been. Under the newest order, which calls for plans and actually to bring workforce reductions into line with the proposed budget, HHS has followed up the OMB memo by basically saying, we're not going to do any hiring. So we're still in this hole where supposedly there are exemptions, but whether in fact they're being implemented, we really can't tell. FDA, again, it's a particular problem for FDA because it needs so many specialized individuals. While they certainly need their share of clerks, most of the workforce has some degree of specialization, and so it's not easy to recruit. So we're taking it as equally important with the funding issue. It will be a main plank when we're down on the Hill. We think the Hill gets it. There have been several letters to OMB from the Hill discussing the employment portion of it. Congress, as I think everybody knows, as recently as December through the 21st Century Cures Bill, but change the rules to make it easier for FDA to hire. So very much a threat to the agency. If it gets the money but doesn't get the employee slots, there's a huge problem. Does that answer you? Is there your question? Is there something else?
No, that was a useful overview. Thank you, Steve.
Great. Does anyone else have any questions for Steve? All right, well, thank you, Steve.
Welcome.
Okay, I'll be giving an overview of the Foundation's work on newborn screening in Florida now. Just gave a talk a little bit earlier today at the Cure SMA conference, and this is going to, for those of you in the SMA community, this might be a little duplicative, but it's for those of you who haven't been following our newborn screening work. We've been working to both speed and improve the current newborn screening system across the states. Currently, there's a patchwork of state laws where some states screen for as few as 29 diseases at birth, and other states screen for nearly 60 diseases. And unfortunately, to screen for a new disease, each state has to introduce new legislation. So the work for patient advocates has been to basically go state by state, disease by disease, to improve each one of those systems. The federal government does make a recommendation of diseases to be screened for. It's known as a recommended uniform screening panel. But once that recommendation is issued, it's not binding on the states, and on average it can take up to 8 years before a state begins screening for that disease. We can, of course, do much better than that. You know, there's no reason why an infant born in one state should have the ability to be screened, diagnosed, and treated, while an infant born in another state has the disease progress many years before they're able to get a diagnosis. So we're confident that universal newborn screening can ensure that no baby is left behind. And by screening from birth, we can ensure that we're saving lives and saving states money from misdiagnoses and expensive surgeries. So as I mentioned, every state's different. This is an old map from 2009, but even then you'll notice that Texas was screening for 29 diseases, and Minnesota was screening for 54. That's nearly twice as many diseases, to give you an idea of how much work has needed to be done. And thankfully, we've had many advocates who have been working hard to ensure that we are able to bring those other states' screening programs up to par. So after finishing our California legislation last year, we were looking for other states in which we could introduce legislation to improve their newborn screening programs. And we turned to Florida, which has the 4th largest number of births in America, to 215,000. And Florida screens for every disease on the rust except for ALD, MPS I, and Pompe, which would ensure that it wouldn't take a whole lot of work to be able to get them screening for all of the federal recommendations. For those of you who recall, our Florida legislation provided that Florida would screen for any disease once it's added to the RUSP within a 2-year span of time. Unfortunately, that type of bill is unconstitutional in Florida. Florida has a constitutional provision that says that they cannot defer to any federal standard in any of their laws. So we have to think a little bit outside of the box to deal with this problem. Florida already has a Genetics and Newborn Screening Advisory Council, which is comprised of 15 members and meets twice a year, and they already make recommendations. However, they don't necessarily do it because something's been approved by the RUSP, and additionally, the governor didn't include their ALD recommendation in his budget. So even though they made the recommendation, again, it's not binding. So what this legislation would do is it would require the council to review new diseases within 1 year of their addition to the RUSP, and then it would allow Florida to screen for a disease within 18 months of being approved by the council. And what that means is once the council approves the disease, their Department of Health would put in a budget request, and at that point, rather than simply leaving it outside of the budget, they'd have to have at least a conversation about it, if not begin screening. So we found 2 members of the Florida Congress of the Florida Legislature, to push this bill forward. It's bipartisan. We have Senator Lauren Book, who's a Democrat from Fort Lauderdale, and Representative Heather Fitzenhagen, who's a Republican from Fort Myers. Senator Book is a freshman senator, and she just recently gave birth to twins, and this is actually her first bill that she is bringing to the floor, or she has brought to the floor, and we'll let you know a little bit more about that shortly. But there are a number of important dates that are coming up. April 25th is the last day for committees to meet and consider bills. May 5th is the last day of their legislative session, and from the day that a bill is passed off the floor, the governor has 15 days to either sign or veto it. If the governor does neither, it automatically becomes law without his signature. So far we've done, we've worked with our grassroots partners at March of Dimes, National MPS Society, AMDA, and the Muscular Dystrophy Association to get their support and expertise, and we've had a large number of patient organizations sign on as well. We hired an experienced lobbying team, including Ron Book and Kelly Mellette, and we identified the sponsors that I mentioned earlier who serve on the Health and Health Appropriations Committees to carry this legislation. We presented to the Genetics and Newborn Screening Advisory Council back on February 3rd before introducing the legislation to get some input on what would be feasible, and that's how we came to our current proposal. And finally, we've passed every policy committee unanimously. The Senate bill, additionally, was heard on the Senate floor today and passed unanimously on a vote of 38-0. So thank you to everyone that's on the call who's helped us with that effort, whether by making calls, signing on to letters, or simply spreading the word. You know, we have the House bill being heard in its final committee tomorrow, and it will also soon be headed to the floor. So we're really looking forward to sending these bills on to the governor's desk. As you can see here, we have a picture of Representative Fitzenhagen with Eileen Baskell, who's an MPS I advocate, and George Fox, who runs the Phoenix Fox Foundation as a Pompe advocate. There are many ways in which you can help. We're getting close to the finish line, but we, of course, welcome all of the assistance, and it's a way to ensure that we can all stay activated, especially as we move on to other states. We urge you all to submit patient stories, if you have some, that can illustrate why newborn screening saves lives and the number of surgeries and misdiagnoses that can be avoided. We also urge you to use the action alerts share the action alert with your Florida contacts so they can contact their legislators. And if you're located in Florida, we strongly urge you to contact your legislators as well. You can also sign your organization on in support, and I'll show you how to do that shortly. And of course, if you're interested in testifying in Florida, you can reach out to us. We'll have the contact information at the end of this slide deck, and you can visit everylifefoundation.org and get in touch with either myself or with Max or with Julia Jenkins, and we can provide assistance in getting you to Tallahassee or to a future state in which we can work on newborn screening. We're always looking for economic data. Unfortunately, there isn't a wealth of information that shows the specifics of how newborn screening can save money through avoiding misdiagnosis and surgeries. California had done an internal study that found that California saves $9.32 for every dollar spent on newborn screening, but that only applies to California. So we definitely like something that's a little broader that we can use as we move forward with these initiatives. And finally, we have a Community Congress working group on newborn screening that works as our brain trust and our roundtable, providing expertise and ideas that we can share. This is free to patient organizations that would like to join, and if you're an industry partner, we'd like you to reach out to us and we can give you details on that as well. In order to find out how you can help, we urge you to visit the Newborn Screening Action Center, which is at rarescreening.org, and this website includes all of the current events surrounding newborn screening. We're still working on populating it, so if anyone has ideas, you can definitely contact us. It includes the Florida legislation, what we did on our California legislation, as well as links to similar bills in Oregon, Missouri, and other states. And finally, this is actually a little bit broader than just newborn screening because it pertains to many other issues as well. The Every Life Foundation is going to be going on the road this summer with Global Genes to 3 cities on our program known as Rare on the Road. This is our Rare Disease Leadership Tour, and at each one of these events, we will be training advocates on everything from building their support networks all the way through meeting with their members of Congress and enacting long-lasting change. These are all-day events, and they'll be taking place in Atlanta, Georgia on May 13th, in Kansas City, Missouri on June 5th, and finally in Portland, Oregon on July 15th. If you're interested in joining for any one of these dates, you can definitely visit raretour.org. That's RARETOUR.org. And we look forward to seeing you all there. Of course, this isn't limited to people in those states, so if you're anywhere nearby, definitely consider attending. And with that, I'm going to open up the lines for questions. I did notice that we received one a couple of moments ago, so I'll answer that first. So Robert Rauner has stated that the state of Nebraska will have its final reading on their bill to add XALD, Pompe, and MPS 1. This should go to the governor for his signature this week. That's fantastic to hear. Definitely get in touch with us, and we, of course, we would love to help, and we'll share it on the website and do anything we can to support. If there's an action alert, we can also post it on the Rare Advocates website. So get in touch with myself or with Max, and we can do that for you. Sarah Tompkins has mentioned that she will be unable to travel to Oregon for that event, and she's wondering whether there will be info available online. I believe Stephanie might be on the line.
Hey, Vicki, it's Stephanie. We're not able to webcast the meetings, unfortunately. I mean, we will have, so part of the goal of those meetings is to help advocates prepare to join us for in-district lobby days. In that program, we'll set up meetings for advocates with their representative and U.S. senators at the dates that they tell us that they're available. And so we'll have a webinar, and we'll have the one-page backgrounders, and that will be, since the summer recess is a little bit later this year, we can talk about that in upcoming, in a future RDLA webinar. But unfortunately, the 3 Rare on the Road events are not going to be webcast.
Stephanie, you also wanted to make I saw you saw a message about adding an additional comment regarding Rare on the Road.
Yes, I wanted to let the folks who have joined us on the webinar know we are able to offer a limited number of $100 travel stipends for advocates who might not otherwise be able to join us for any of the 3 events. The deadline to apply for the travel scholarship for the Rare on the Road in Atlanta is tomorrow, April 20th. And then for the other 2 events, it's a month before. So for Kansas City, which is taking place on June 5th, the deadline to apply would be May 5th, and for Portland, Oregon, because it takes place on July 15th, the deadline to apply for a scholarship would be June 15th. And you can find more information on those on the Rare on the Road tour in general at raretour.org.
Thank you, Stephanie. Does anyone else have any questions? Okay, well, I thank you all for joining. This is actually going to be my last RDLA webinar, as I'll be leaving the Every Life Foundation and RDLA next week, and actually we'll be moving to Kansas, but I will be at the Kansas City Rare on the Road event. So those of you who are there, you'll definitely see me, and I definitely look forward to working with many of you in the future, and hope to hear from you all soon. But thank you all for joining and for making this a great call. Additionally, Stephanie has tweeted the links to the bio principles and to the Alliance for Stronger Fda website. So make sure to follow both Rare RDLA as well as the Every Life Foundation on Twitter, and you can find out more information there. And finally, I just want to note that our next RDLA meeting and conference call will be on May 17th at 1 p.m. Eastern. So make sure to put that on your calendar, and I hope you all have a great day.